Welcome to today's SEAside webinar, a nursing liaison's role in evidence-based practice. My name is Liz Waltman, the Outreach, Education, and Communications Coordinator for the Southeastern Atlantic region. Before we begin with today's guest speaker, there are a few administrative details I am going to go over with you. As you are sharing, communicating, and asking questions in the chat box, please be sure to send to all attendees so that I, our guest presenter, and your colleagues can see your questions and information shared. There will be points during the session where we pause for questions and comments, but there will also be time at the end for any remaining questions. If you need closed captioning for today's webinar, I will post a link to that in the chat box. This is the same URL that you currently see on your screen. Today, our guest speaker is Roy Brown. Roy is a research and education librarian at the Tompkins McCall Library for the Health Sciences at Virginia Commonwealth University. He serves as liaison to the nurses of VCU Health and the VCU School of Nursing. As part of this work, Roy serves on VCU Health and School of Nursing evidence-based practice and research committees. He also supports the VCU Health Nurse Residency and the Nursing Interns and Scholars programs by working closely with administrators overseeing the program as well as with participants. Roy has presented on his work with these groups, including successful EBP tools and strategies he utilizes at the American Nurse Credentialing Center Magnet Conference, the ANCC Pathways to Excellence Conference, and other state and regional nursing conferences. Everyone, please welcome Roy. And Roy, I'm going to pass you control, and then the floor will be yours.
All right, I should be live and ready to go. Thank you, Liz, and welcome everybody for coming. I hope that what I provide you with today will be of use and of some interest. And if you have any questions, don't hesitate to put them in the chat box. As we get to pauses in the presentation, I'll be happy to answer those. But I hope that everyone finds this to be very useful. I know that you wouldn't be attending if you didn't have some interest in evidence-based practice. You may have at least heard about it, or you may be presently supporting it. And so to start this presentation, what I would like to do is just kind of see where you all are at as far as your support of evidence-based practice. So this is an opening question I would ask that you put any responses that you would care to share in the chat box, and we'll just go from there. And I'll give you a minute or two to do that, because I'm just curious as to what people are doing. Starting the magnet journey. That's an interesting journey to get on. All right, so what I see here are a lot of, everybody seems to be involved in education, serving on some sort of committee or council, supporting Magnet in some way, which is kind of interesting because it opens up a myriad of other things that you could potentially be doing, because Magnet is not just evidence-based practice, but the use of evidence for research and shared governance and all kinds of things. So this is a pretty good list, and there'll be many of the things I also talk about, but I also hope to add some things to what you're doing. And I'll talk about Magnet, Jane. I see that you've put that in there. But that's where we're at with this. So, all right, so mainly education, serving on committees, it looks like, helping with the magnet journey, which is an interesting thing which I have done for several years, and so that's kind of this is very much in line with many of my own experiences. Here's a second question, and this question may be a little bit more enlightening or interesting to some, and that is, what barriers are you have you faced or are facing when it comes to supporting evidence-based practice? So I know what you all are doing, but are you seeing any barriers that you're coming up against where you would like to do more, but you're not able to do what you would like to do? Time and resources. Yeah, money becomes a big issue. Staff becomes a big issue. Yes, staffing limitations can become a big thing, because I think many of you, as you find once you get into helping nurses and they see value in you, they will definitely utilize you in ways that maybe other disciplines won't. Ooh, staffing. You're one person for 4 medical centers. That's a lot of folks that you have to do. I'm fortunate. I hear you, Jody, on the culture in the hospital not always understanding what EBP is, and I'll talk about that a little bit today. Okay. The firewall. That's also interesting, because hospital IT is an animal unto itself that's not always easy to navigate, and so that's kind of interesting. All right, so it's very interesting to see where you're coming from and the barriers you're finding, because there are many of the same barriers I have or I have had, and some of them still exist, but I've tried to find ways around them, like some of the technology stuff. I'm fortunate. I'm at an academic medical center here at VCU, and so I also not only have hospital resources, but I'm very fortunate in that I also have the resources of the university. And so what I'm going to do with you all today as we kind of get into this is I have really 3 basic objectives. One, to understand the place evidence-based practice has in healthcare today, and why it's become central to nursing practice. I know when I started supporting nursing, this wasn't something I had a full grasp of, and as I've become better at understanding the place of evidence-based practice in healthcare, it's helped me to better integrate myself into the health system as well as the School of Nursing here at VCU. So I'll talk a little bit about that. will talk about how to help you understand the difference between evidence-based practice, performance improvement, and research. As you could tell from Liz's introduction, one of the things that I've done is I've gone to a lot of nursing conferences, and one of the things that I find that's happening there is a lot of times what people will do is they'll use evidence-based practice in a very generic way to mean anytime I'm using evidence, I am doing evidence-based practice, which isn't exactly correct, because you could use evidence for performance improvement. You can use evidence also when it comes to research, so I'll also talk about that. And then lastly, to wrap this all up, what I also will talk about is how you can identify opportunities that librarians can leverage to support the evidence-based practice of nurses, which is the main focus of all this, but I feel like laying the groundwork is pretty important. And so with that, I also want to make the caveat that you'll notice I will show you a couple resources and pictures or diagrams. All of those diagrams I have provided links to on a handout that I provided to Liz, who will either share it with you as a link in the chat box at some point, or she'll definitely give it to you towards the end of the program or in the follow-up email. So don't feel like anything I'm showing you I'm happy to share, and so I have put that together as a handout that I hope that she'll give to you, and I've also placed it as a hyperlink on the last page of this particular presentation. So with that said, the last thing I need to say is you'll see me talk a lot about this from a hospital perspective, because just like you all, I'm very focused on the magnet journey with the hospital I'm at. They've done it 3 times. We're in the process of going for the 4th accreditation. And so a lot of what I'll talk about is the skills and things to get into the hospital, but I also will talk about how that translates back to the School of Nursing, because I have found it to be an interesting journey to be able to live in both the academic world where the nurses are being educated and trained, as well as once they graduate, when they go to practice, and seeing how what they've learned in the School of Nursing translates truly to the hospital, and how I've tried to help bridge those gaps. And so with that said, we'll kind of go on and see what we can accomplish today. All right, so healthcare today, why evidence-based practice is becoming central to practice. This will be the first thing I talk about. And while evidence has always been important, I really kind of think about it starting in earnest in 2001, when the Crossing the Quality Chasm report of the Institute of Medicine came out, or the National Academy of Medicine now, in which they talked about there being 6 aims for improvement to bring healthcare into the 21st century to ensure that patients were getting the care that they needed. When it comes to evidence-based practice, I think the most important one was the one about effectiveness, where they discuss applying science and evidence to improve care, which is why it becomes so central to nursing practice as well as the practice of other health practitioners. Of course, safety is also key. Patient-centeredness is also key, which, as you know, when it comes to evidence-based practice, everything is predicated on what the patient's values are or what they're willing to do, as well as efficiency and equity, which is closing those inequity gaps that you find between races, between people of different incomes, or depending upon where you live, you will find that your life expectancy isn't nearly as long. And so this really, I felt like this report really starts the conversation in a way that I feel is meaningful to get people to start to think differently about how it is they should care for patients. That's been further translated, and this is something I know is talked a lot about in medicine, is the triple aim, and in some places you're seeing it moving to what they call the quadruple aim, which is taking those things that you found in the Crossing the Quality Chasm report and trying to translate them down to things that are more meaningful to give the health systems something to aim at. One of the major things they're looking at is patient care, making sure it's of quality and that patients are satisfied, which makes things very difficult sometimes because you can't always satisfy everyone, but it also helps to make sure that you're giving what they call culturally congruent care or culturally appropriate care. And so this is kind of a really interesting thing. But as we've done this, where we've become so patient-centered or so patient-focused, we've done that to improve quality and satisfaction, but we're also looking for ways to drive down the cost of healthcare, which is kind of an interesting way of looking at things, that everything is now predicated on the bottom line. And one of the ways to kind of help with that cost containment is not only to do things better and more effectively while they're in the hospital to ensure that they don't stay in the hospital, but also trying to prevent them from not being in the hospital. So what you'll see here is that they also talk about population health, which is, helping people to live better and more healthy lives so they don't end up in the hospital for unnecessary care. You'll notice for some, and this is kind of a new concept, you're starting to see in the literature a conversation about what they call the quadruple aim. One of the things that you're finding there is that they're adding a fourth piece about care team well-being. You'll also see it called joy, work joy, or care team joy, and all they're really talking about is finding ways for healthcare professionals, nurses, and others to make sure that they are mentally well as physically well in order to ensure that they can care for their patients. Because if you're not physically or mentally well, then you can't effectively care for anybody, which then kind of drives up the cost of health care, and overall the population's health is not great. You see this in nursing, for you all who are very focused on nursing, with the Healthy Nurse, Healthy Nation initiative that the American Nursing Association has put out there to help nurses to live more healthy lives so that they are healthy and feel better so that they can provide adequate care to their patients. And so what you're seeing is this translation of those ideas of the Crossing the Quality Chasm come to the triple and quadruple aims, as well as finding it translated into what I say is government policy and reimbursement. Like, one of the things that my hospital, and I know many hospitals, are very focused on is making sure that when they care for a patient that they get the funds necessary to do that. And you know, everything takes money, but how that money is provided is largely now based on evidence as well as patient satisfaction. You can see that government policy has really changed with the Affordable Care Act. It has expanded the access to health insurance, which then has expanded access to care, which has got more people in the system. As more people have come into the system, efficiency and cost and all those things have become a real concern, because we're trying to give everybody the best care possible at the place where they are, but it's hard to watch the bottom line when you feel overwhelmed by the number of people coming into the system. But the Affordable Care Act is really driving some of this stuff about evidence and doing better research so that we can find the best way to care for patients, or the best way to move patients through the system in the best way possible. Because as a result of the Affordable Care Act, which you also see is the government policies with the Centers for Medicare and Medicaid Services being very reimbursement focused on evidence and patient satisfaction. Like you'll notice, you all who work with the hospitals, that they're very into the patient satisfaction numbers. If the patients aren't happy, Medicare and Medicaid is not happy, and therefore, you know, reimbursements suffer. They especially suffer when it comes to readmissions. You know, and that 30-day readmission rate, if it goes up, money goes down. And so what you're finding is that hospitals and nurses are trying to work together in order to find the best way to care for patients, to make them healthy when they leave so they're not able to come back. Because the other thing that will be a ding for in the hospital setting is length of stay, and throughput become also major factors. Like you know, if you have a procedure, you're only allowed to be there so long. If you're there longer than that, then the reimbursement isn't the same. And so you also will find that hospitals and nurses are very focused on this length of stay as well as throughput. Like, they don't want people staying in the bed longer than they should, because the more people in bed, the fewer people that can be cared for as they come in, and so they become turnaways. And then the third factor in all this, when it comes to money, is that you're also finding that insurance companies or private payers are also really sticking to not just trusting what doctors or nurses want to see happen when it comes to care, but looking at seeing what the evidence is saying as to how effective that care is before they're even willing to reimburse for it. And so, you know, all of these kinds of things, when it comes to reimbursement or readmissions or whatever, evidence is becoming key to every decision. It can't be like it was before, where we made decisions just because we felt it was the best thing. It can still be the best thing, but now we have to back it up with evidence. And so when you move from that, the other part of this that I think is pretty interesting is that as we've made these different government policies and we've shifted reimbursement a little bit, you're also starting to find that we're just a litigious society, that more people are more than willing to start to enter the legal system and sue when something, an adverse event happens in the hospital. The reason I bring this up is that a lot of times especially when I work with new nurses, they'll act as if evidence-based practice is an academic exercise, especially nurse residents. They'll tell me, it's like being in school. I don't want to be in school anymore. And one of the things I try to stress to them is that when it comes to this, the reason evidence and the use of it is going to be so important is that if you should be sued because of an adverse event, not every adverse event can be prevented. So therefore, you're going to have to make sure you have the evidence that's on your side, because if you get sued or you show up in a criminal case, I can guarantee the prosecution or the lawyers on the other side are doing their research to ensure that what you did was in line with what the best practice was at the time. If nurses aren't able to utilize information effectively, that becomes an issue, because that means that you may not be practicing to whatever the present best practice is, because you're not aware of the evidence that supports that. And so it's really important that evidence-based practice become a key to nursing practice, because everybody's watching, and therefore to make sure that you protect yourself, you need to make sure that you are in line professionally with what the best practices are. And so what you're seeing is, if you want to kind of think of this a different way, is that there's a real mind shift based on government policy as well as other changes, where we're going from a time when healthcare practice was based upon people's opinion, whether it be their own or their colleagues, past experiences, precedents they may have heard of, even if they just passingly read it somewhere. They're like, look, I'm credentialed, I can make this decision, this is the way I've always done it, this is the way we're going to do it. Whereas today, because of all these different mitigating circumstances that are coming up in society, we're moving to a more evidence, science-based decision-making model, which is really pushing nursing to have to get on board in a way that some find very challenging. But this challenge is even being exacerbated more, because if you follow what's going on in nursing, because of the Affordable Care Act and this opening up of access to health care, what you're finding is that more and more people are getting involved in health care, and there needs to be more people to care for them. Well, what's happening with nursing organizations is they're really pushing for nurses to be able to practice to the extent of their education and experience. The American Nurses Association has done this as it relates to registered nurses, and the American Association of Nurse Practitioners are really doing this big time at the state level to push to allow nurse practitioners to practice more independently, or at least to increase their practice authority. And with varying degrees of success, all of this has happened. As the number of things nurses are allowed to do and that responsibility increases, what you're starting to find, I especially see this with master's students, is that they're being asked more and more to go ahead and be able to utilize literature and evidence in order to make decisions for patients to ensure that it's the best one possible. I see your question, Amanda, and I'll try to answer it when I get a break here in a minute. And so this is kind of interesting, that we're having this big push where the government is doing things. You're seeing people who do reimbursement are changing the way they do things, and now you're further seeing, because of all those changes, that nurses are actually demanding more responsibility, and with that, evidence is becoming key to that kind of conversation. Now, where you're seeing that even trickle down more, and this goes probably to you all who are supporting nursing education, is that you're finding that it's trickling down to where nurses in BSN programs or master's programs and the like are finding themselves having to really get in line with being able to utilize evidence effectively. You see that with the Future of Nursing report, where there are key competencies that address research, process improvement, and evidence-based practice, saying that, hey, this needs to happen in order to move nursing forward to meet the needs of patients, as well as when it comes to the nursing curriculum. The American Association of Colleges of Nursing have various what they call essentials. There's ones for the baccalaureate, master's, as well as the DMP, in which they are really instilling that these things need to happen in order to be able to be an effective nurse at these levels, with one of those things being able to utilize evidence. And then what you're also seeing in nursing education is an explosion of programs called the Doctor of Nursing Practice, which is a practice doctorate, in which you're really being focused, they're really focusing on evidence translation. I know at my hospital, and I'm sure it's true at many of your hospitals, what we're finding is that the DMPs are being looked at once they graduate to be the people that take the lead to implement better practices to improve nursing care at their institutions. And so all of this is making a real call for librarians to get involved, because what I'm finding, and I'm sure you're finding, is that even though we have all these things, nurses at various levels are still not prepared to deal with the evidence that's out there. And so there's a real role for nurses in all this. But what you're seeing is this real change towards going towards a more effective way of doing things. And while I know this may not be clear depending upon your screen, one of the things that's been further done, and this is really helpful for nurses in the hospital setting, is that Dr. Bernadette Melnick and her colleagues at the Fold Institute, which is the EBP Institute at Ohio State, that what you're finding with them is that they have come up with a set of competencies that they are encouraging people to use to incorporate into their education to help those bedside nurses to be able to effectively deal with evidence so that they can make best decisions for their patients. And this is based on some studies they've done. I provided the citation. It's really interesting about how it is that nurses need to be able to do things in order to be able to effectively get involved in evidence-based practice. And so I just like that. I like these competencies because they kind of lay it out, and you'll see here from a very registered professional nurse level to a more advanced level for the advanced practice nurses. And so you all who work in a hospital setting where there may be a clinical ladder, I know here this is something that they have really looked at, because as we've moved from the education and having this forced down on nurses' practice, what you're starting to see is that the organizations are trying to change to empower nurses, which means that they need to be prepared to deal with evidence. Many of you who work in a hospital most likely have what they call a clinical ladder, or you may call it a professional advancement program. I've seen it called a career ladder for some, in which what happens with nurses is that depending upon their education, experiences, and years in the process, I have it on the resource handout, is that this clinical ladder, as you go up the ladder, what you're going to find is that nurses are asked to do various things clinically, and one of those is evidence-based practice. And then on the rung, to say it goes from 1 to 5, at 1, you may need to be able to demonstrate that you understand what evidence is and where to find it, to step 5, where you're asked to do more complex things, such as not only lead an evidence-based practice initiative or project, but also implement that practice to effectively change what's going on in nursing in your organization. And so you're seeing these real pushes, because with every rung in the ladder comes more money, and with more money, comes more responsibility. You also, many of you who work in health systems may also be familiar with the nurse residency program. If you're not, what it is it's just a transition program for new nurses to go from being new graduates to being full-fledged bedside nurses. And during that transition, which tends to last a year, they're asked to do some sort of evidence-informed project, whether that be a performance improvement project or an evidence-based practice project. That's one of the things that they're asked to do. And so just as soon as they come in, they're asked to use evidence because of all these outside pressures to improve care and drive down costs. And then lastly, what you'll notice is that there are also organizational programs out there, one of those being the Magnet program as well as the Pathways to Excellence program. The simple way to put both of these programs together is that they're both programs that are set up to empower nurses to make decisions. There's a shared decision-making model to it, but there's also the factor of that any decision you make has to be made on evidence. Like, one of the things that keeps me really busy here is that anytime they want to make a practice change here, it can't just be a good idea. They have to be able to back it up with some legitimate evidence, because they understand that any change that you make just doesn't affect nurses, but it affects other disciplines. And so overall, what you're seeing is that there's this real drive towards improving nursing through the use of evidence, and they're finding different ways to force the hands of those who may be a little hesitant to get involved and engage with evidence, which leaves a real key place for librarians to become involved. and in that involvement, you'll get into things like the sacred cows. Like one of the things, I only bring this up because I read a lot about this stuff, and I have people come to me and they'll ask me, well, what is these sacred cows? What you're starting to see as nurses are becoming more empowered, those things that we've done that are traditional or outdated, that aren't supported by research, are going away. And as that happens, there's a larger demand on the system to find evidence, which then leads to us being more important to them. Now, with that said, and I'm almost to a pause or a break here, one of the things I think that is important before we get to talking about the role of the librarian is talking about what evidence-based practice is and what it isn't. Because as I stated at the beginning of this, one of the things that I'm finding when I read the literature and when I go to conferences is everyone will tell me, well, I'm doing evidence-based practice. And when you start to talk to folks, what you may find is that they're doing something very different than that. Just because you use evidence doesn't necessarily mean you're doing evidence-based practice. You may be doing what they call evidence-informed practice. Like evidence-based practice by the letter is really the translation of evidence to change practice, whereas performance improvement is where you may use evidence and translate it in order to enhance or revise something that you have going on in your present situation. You may not be doing a whole full-scale change, but you still may be using evidence to translate. And then research isn't just searching the literature, which I know we all have heard. It's where you actually are going out and doing knowledge creation. Now that doesn't happen a lot depending upon your setting, but it is out there. But I think it's important to kind of put these all out there, because while your inquiries may be very patient-focused, and you may need to be able to use evidence, the reason you're using it may be very different. And if you get into talking about evidence-based practice as a team sport or patient care as a team sport, I think it's improvement that I think it's important that there is a baseline of understanding of what the difference between the three things are. And one of the things I've done at my institution to do this is I created an inquiry process diagram which takes nurses through the process to not only understand that, that they have a question, but what happens with that question depending upon what they find. As I stated before, this is on the handout that Liz will provide to you. And what you'll notice is that everything that nurses do, when you come up with a question, you always start at the beginning. You always start with a question and you start to kind of work the question, finding evidence, talking to people, appraising the evidence and looking at what the quality is, to the point where then you have to make a decision that if there's no evidence to answer your question, you're doing research. If there is evidence and it's not the current practice, you may be doing an evidence-based practice project, which means you go down the green side, or you may find that you may be doing part of what's going on or not fully doing what's going on, which then means, yes, there's evidence for you to do something to change or adjust practice, but instead of doing the whole green line, so to speak, of evidence-based practice, you may actually be doing performance improvement. But in all these cases, I think the other thing that people lose sight of is that while it's important to be able to utilize the evidence, you also need to be disseminating it. I think one of the things that probably drives all of us a little crazy is that when you go to a conference or you start talking to nurses, you probably notice pretty quickly that the questions they're asking are the same questions you've heard for the last 5 or 6 or 7 years, or in my case 8 years where I've been, where they're still looking at falls, or they're looking at nurse satisfaction, or they're looking at these things. I think it's really important, and where we can play a key role that I'll talk about later is in this dissemination. But this just kind of graphically takes what the differences are and gives you a way to kind of step-by-step through this. Because what my experience has been is that even new nurses, even if they've taken an evidence-based practice class, they don't fully understand the process. They think the process is doing an evidence table after doing a brief literature search and laying out that table and telling you what the levels of evidence are. Very few of them understand that there's more to it than that. And so I think it's important that you have something like this to kind of really give you a baseline of discussion, because that importance of evidence and being able to use it is something you've got to come up against. Which leads me to this slide, which is dealing with the fact that You also will see evidence-based practice called various things. You'll see it be called EBP, or evidence-based nursing, or evidence-based medicine. The reason that I feel conflicted about this, or why I bring it up, is that everybody's doing evidence-based practice. It's the overall process of using evidence to make the best decision. Where you see this difference between what they call evidence-based medicine, evidence-based nursing, is that the orientation of the disciplines is very different. What you'll see, one thing is that when it comes to evidence-based medicine, doctors are very focused on diagnosis and treatment. I went to a workshop a couple weeks ago that was an evidence-based medicine workshop, and everything we talked about mainly focused on diagnosis and treatment, because that's mainly how doctors view patients and their care, and everything is clinical decision-making at the bedside. Whereas when it comes to evidence-based nursing, partly because of how nurses approach patients, there tends to be a very more holistic view when it comes to using evidence. It's just not about diagnosis and treatment, but it may be in preventing something from happening or trying to learn the cause of why it is that they're having difficulties. And that many things that nurses do tend to be project or initiative-based as compared to the bedside decision-making that many doctors have to do. But understanding the difference is very important, because when it comes to all this, all the care of a patient is interdisciplinary. It's a team sport. So getting on the same page and understanding where each person's coming from, I think, is pretty important. Because one of the other things I've found to be pretty interesting is that when this has come up, like I was at a magnet conference a couple years ago, there was a person who stood up who called evidence-based practice, they called it cookie-cutter care. And what I had a conflict with that about is, when it comes to evidence-based practice, I think everybody also needs to keep in mind it's really like a three-legged stool, or there's three parts to it. And one of those is your clinical experience or expertise, as well as the best available evidence, and then combining that with what the patient values are. So what the best care for one patient isn't necessarily the best care it is for another. And so kind of keeping that in mind, I think, is pretty important. But also understanding that this is kind of the world that nurses are living in really allows us to be in a really good spot in order to help them and to serve them. So I will pause right here before I round this up by talking about the librarian's roles, potential strategies you could use, to see if there are any questions or anything I need to address. And Liz, you might need to help me with this if there becomes several different questions, because I only do one at a time. Oh, Susan, I see your comment about the lip service to evidence-based practice. I totally agree. It seems that one of the biggest barriers I find for nurses when I talk to them deals with time. And I'm sure some of you also have the fact where you're expected to do evidence-based practice they're supposed to do it on their own time, or they have to take what they call non-productive time, which also communicates exactly what you're saying, that they're saying evidence-based practice is important, but the only way I'll allow you to do it is if you take what they call non-productive time. When you're doing evidence-based practice, this, aside from direct patient care, is probably the most important thing that you would do as a nurse or as any kind of healthcare practitioner. Oh, so I see that you have one other one here. What should nurses do when they are aware that guidelines have updated, but the unit has an outdated protocol? So my best advice to you with that, and I've talked about that with our nurse residents because it's one of the first things I ask them to do, is I would tell them to take the evidence, and this is the important part, and this is why they need those skills. They need to take that evidence and go to one of the decision makers and see what can be done to change that protocol. You may not be able to do it right away, but by not saying anything, that's not professionally smart either. If you're doing the best thing for your patient, the best thing you can do for them at that point is to advocate for them. And that's not to say go rogue, but you definitely would have to bring that to the attention of your supervisor and the practice council that may potentially be involved in that. All right, nurses, what track they need to go down? We are being pushed to do research because of magnet, but just don't know when. Okay, so Steph is asking a question about this push to do research because of magnet. Magnet is an interesting animal that I'm actually going to do another presentation in maybe probably 6 weeks, as soon as Liz and I get on the schedule, where we'll talk about magnet and all that kind of stuff. But when they're being pushed to do research is kind of interesting, because it is something that Magnet's doing where they're saying, hey, you need to have nurses doing research. The problem is I don't think most nurses are equipped to do research, and research is pretty time intensive. It's kind of, it's interesting. And I don't have a sound answer for you when it comes to that. You said we were being because of Magnet, I just don't know where to begin, or I feel like I do not have the expertise to advise on how to plan it. I don't think, Steph, that would be your role. What I would suggest that you do when they come to you with a research project is hopefully you've networked enough with people in your organization to find someone to help them, because that's kind of an interesting piece there. It's an interesting thing that's a real conundrum where I feel like, and we're going to talk about this in a minute, they kind of, once they see value in what librarians do, many nurses and nurse administrators who may be already overwhelmed with other things are turning around and saying, well, a librarian can help you with a research project, which is not something we're really all trained to do very effectively. And so what I would suggest is that you turn around and try to find someone for them to go to who could better support them. And I'm sure within your organization, or even maybe slightly outside of your organization, there has to be at least PhD trained nurses that could assist. Like if you're near a school of nursing, that would be an ideal place for to turn them to. Yes, they get it. They get it real confused. All right, so I think that I've answered everyone's questions. If I have not, we'll try to get it at the end, but I'll try to keep us on time here and talk briefly about the roles and strategies that we can use to do that. Because one of the things when it comes to evidence-based practice is, it's probably, when I talk to hospital nurses and they're telling me, well, oh my God, I may lose my job, or that they're being cut, my first thought is, there's something going on there, because evidence-based practice, in my mind, is one of those things that really allows librarians to really get involved in the nursing process as well as the process of other healthcare practitioners, and be able to show their value. Now, so what I'll do here for the next couple minutes is talk about what I view as some roles and strategies that you could use potentially to support evidence-based practice. Now, I know some of these will be ones that you already know, but I hope to provide you with some new perspectives. And so we'll go from there. And I totally agree. Administrators tend to not have any idea what's involved in research. They don't always have a full idea of what happens or what's needed when it comes to a full-blown evidence-based practice project either. And so we'll go from here. So when it comes to the role of the librarian, you know, of course, there's general roles you can play. I mean, of course, the most traditional one, and the one I don't need to tell anybody because everybody put it in the box, is that we assist with finding evidence and do literature searches. That's kind of the most traditional thing we do. I would also suggest, if you haven't, finding a way to find partners, especially within the nursing education professional development partners or departments of your organization, because those are the folks who have all the nurse educators. The nurse educators, part of what they're tasked with, especially if you're a magnet organization or one who wants to be driven by evidence, which they have little choice in, it's the place where all the education happens, and it's a real right place for you to get involved in assisting with classes that address various aspects of evidence-based practice. It may be the whole process, or it may just be the search. It just depends upon your organization. I'm involved pretty deeply with our EPD department here, and I've found that not only do I get involved in dealing with just the evidence-based practice questions or classes that deal with searching, but I found myself dealing with the appraisal process and other things, and which has been very fulfilling and interesting. I would also suggest, if you can, find your way onto hospital councils or committees, and not just to say that you're there, even though I think that your presence is important, because I think presence is part of the, is just kind of a big part of this. Like where I'm at, I know one of you said you're one nurse for 4 health systems or 4 hospitals. I don't know how this would work for you, but where I'm at, I'm one person for like 4,000 nurses. But by going to these councils, one of the things I'm able to do is kind of spread information through a small number of people and kind of have it fan out, because whether it be the Nursing EBP Council, the Magnet Champions Committee, or some practice council, you know, they're all talking about topics that help to move the organization forward or helping to address patient care concerns. By being there and being able to be present and show an interest in what they're doing, they're able to provide them with the evidence that they need and not just the evidence they want, so that they're making the best decisions possible. Like, it's really interesting to me sometimes when I go to practice councils that have never asked me for any information, and I'm able to find them information they didn't even know existed. Like, one of the things I've noticed a lot about nurses is they feel that they can do this by themselves, and that's not something that's the case. This is a team sport, and you may not have the skills to go in and find all the information, but doing at least these 3 things I think is pretty important. One of the most important things I think, and this is probably the thing I have the most fun with, is you can also serve as a connecting agent. I know that, especially if you get deeply involved, I know this is true in the schools of nursing too, but the more deeply involved you are, the more connections you make, so that when people come to you, you're able to kind of break down the silos. Like, I find myself being a connecting agent for lots of people. They'll come to me with some question they have or some problem they're trying to address, and because of the time I've been here and because I touch so many people, I'm usually familiar with where to turn them to if their question is something that somebody else is already working on. Like, we have some nurses here working on LGBTQ culturally congruent care work, and it was started by a couple nurses, and I had other nurses show up, and I was able to put them together to really help them make it a more rich project that they're still working on. But, you know, by being present and getting involved in all these things, I think that what happens to this is that you're really able to connect people, which kind of gets you into the fabric. The more you're in the fabric, the more valuable you are to the organization, to the point where they don't ignore you anymore. I found that to the point where I wish sometimes they would ignore me. But this is pretty important, this serving as a connecting agent. If you want to break it down in a different way, and this will be the last part of this, is you could also think about getting integrated with nurses based upon the various stages in the evidence-based practice project or in the process, whether it be in the practice question formulation or translation, just wherever you can get in. If you want to think of it that way, this may be another way of thinking about it. Of course, when you assist with question formulation, I think probably the most important thing that librarians can do, because we're so good at finding the resources and also finding the literature and evidence, is helping nurses to take their question and move it from a background question to a foreground question, which means sometimes you got to back a nurse up, because I know that nurses are real good about, they form a question around the solution they believe to be the best solution without always seeing the evidence. And so what I have found is that one of the key roles I'm able to play, and I think many librarians can play, is not only can you help them to access the literature, but you can also help them to think about what internal and external data there may be available in order to help them ensure that the questions they're asking is one that's meaningful and relevant to the organization. Because if they're not doing that, then they're asking a pointless question, because every question or project they come up with is going to have to utilize the various hospital resources that are out there. And if they're not able to put data to that, or to identify the hospital goal that it may align to, they're really wasting their time. Because not only, if they're not able to do that, you know, administration or those who make decisions may or may not support it. It's also what I found to be really useful is helping them to think about how they can figure out what the potential return on investment is for whatever they're suggesting. And what I mean by that is, if you're trying to help with patient with throughput and you're trying to prevent a fall, if a person falls, how much longer are they in the hospital? If they're in a hospital 2 extra days, there are dollar signs to that. And so, like, if you're able to figure out and say that's $4,000 a day, and so that if we can prevent these falls from happening per patient, we could potentially save $8,000. That's something that really gets people's attention. And so helping them think about those things may be a really good thing. I find that when it comes to this, the hospital resources and this return on investment, my connecting agent part of how I view evidence-based practice and my role in it is really, really useful, because I may not be able to get the numbers, but because of my work in the hospital, I know who I can turn to get that. The other thing I think when it comes to the question formulation that's pretty important, that I think librarians can also help with based on that connecting agent aspect of this, is dealing with identifying potential stakeholders. No practice change is done in a bubble, and understanding who else, whether they be other nurses or people of other disciplines who may need to be involved in a project, are pretty important. And to do that early is really important, because if it's going to be something that's going to add time or ask somebody to do something a little extra, having them involved in the process early can really, really help with buy-in. And so I feel these are some really important things that you can do. And of course, when it comes to acquiring evidence, this is a pretty simple thing to kind of think about. I think the thing I do the most here is perform a lot of requested searches, because what I'm finding, as some of you all have mentioned, is that they don't have the time to search, and so I do a lot of the searching for them. They find a lot of value in that, because while they may have to go through the articles, at least I've kind of cut down some of the trees of the forest of information for them to find what they need. But I find this to be my key role of education, as well as trying to find things for them. One thing I think is a little different from what I saw mentioned in your stuff is that one of the things that I do based upon all the meetings I go to, where I'm listening to the various concerns of administration and other nurses, is I've also gotten to the point where you may not be asking me a question, but I'm sure going to give you information or evidence to help you answer questions that you don't even know that you may have. So one of the things I have done here is I've set up search alerts on topics of interest to those in the hospital, and identified who those people are who need to get that stuff, whether it be about falls, or one of the big things in our hospital right now is restraints and throughput, or bed management. And so what I have done is I've tried to show initiative or interest in the topics that they need information on before they know that I'm interested. And so I think this is a really interesting way to get yourself involved, because I have several new administrators who've only been here a short time, and I found that this has been really useful to them in getting me on their radar, to the point now where they're coming back and thinking, hey, this is one of those things that he can help me with, that takes it off my plate. Francis, I will address that point in just a minute, about people should be able to do this on their own. But this, I think, is a really useful thing to be able to do, which is this search alerts on topics of interest. As I roll through this, of course, appraising evidence, not a strength everybody has. If you do, it's great. It's a way for you to show a real skill that is very valuable that not everyone has. But you also need to be aware that when it comes to this, that one of the important roles you can play here is even being able to connect it with individuals that can do the appraisals or help them further than you can. I can't help with every appraisal. I can help with some, but the one thing I feel like I do a pretty good job of that they really appreciate here is I'm able to connect them with people that will sometimes have a better understanding of some of the complex statistics than I will, and I put them in touch with them. So what I tell them, and what I'm always trying to push here, is that I'm all about the quality. I don't have to be directly involved in everything you're doing, but what I want to make sure that you're doing when you're asking questions and coming up with these evidence-based practice things, that you are doing things of quality, whether that's the search, the appraisal, or as I go to the next slide, translating this evidence. And here, I don't think librarians can do a lot of the direct stuff on this slide or on this topic because we're not on the units. Like, I'm not a nurse, and so I don't always understand the politics of what's going on in a unit or what's going on in the hospital. But what I am able to do when it comes to translation is helping them to think about, again, who needs to be involved in order for this to be successful. Like, who are your gatekeepers? Like, who are the doctors who need to be involved in order to get the other doctors in line with what you may be asking them to do? Or what practice council may need to be involved to change something like an outdated protocol. And identifying other hospital resources you may need. Is it technical? Is it financial? Is it data? Like, do you need someone to run your data? Do you need to find a biostatistician? As I said, I'm in a pretty fortunate place here in an academic institution where I'm able to use the resources of the university to help people in a way that not everyone can. But what I also find to be pretty universal that I think many nurses or many librarians can get involved in is helping nurses to think through the process and come up with a project management plan, you know, planning with a goal in mind, coming up with milestones and timelines so that, you know, they don't feel like they're losing momentum when it comes to these evidence-based practice projects. Because I know one of you all mentioned that there are many nurse administrators who don't understand what it takes to do a research project. I also don't think they always understand what it takes or the energy or resources it may truly take to do an evidence-based practice project or initiative well. And so by helping people come up with a timeline, getting them a better set of teammates together, they're able to tell that story more effectively, and they can meaningfully move their project along to improve patient care more quickly. And this is the last of the places I think that librarians can play a key role, and that's when it comes to dissemination. One of the things I do a lot here is assisting them with identifying conferences or publications appropriate for work, which is just basic scholarly communication stuff. But I also find myself partnering with nurses a lot to create educational sessions that deal with things like writing good abstracts, putting together quality posters, or writing for publication, or even, and this I think is a big barrier for some nurses, is effective presenting. Like, one of the things I always have nurses tell me is, I don't want to submit anything that goes to a conference because I don't want to be picked to present on it. And I'm like, slow down. Presenting is not that hard. You just need to be able to become more confident and learn some basic skills to do it well so that you can disseminate your work. Because the more you disseminate your good work, the better it helps with patient care and all those kinds of things. And one of the things that we've done at our institution is we've started to discuss putting items that nurses do into the institutional repository. And one of my roles in that is assisting them with having that work deposited. Because what I'm finding is that not every nurse, and you all have mentioned this, has the time or the skills to write. And so they may not be able to get something published, or they may not be able to get it to a national conference, but they may be able to present it at a local conference, and that may be all they want to do. And so one non-traditional way, I guess, and that's the way I kind of look at it, is to suggest that they put it into an institutional repository where their work and their findings may be discoverable and allow them to connect with other people who may have the same questions. And so in wrapping this up, because I'm to the last slide, I think that you need to identify partners in your organization when it comes to supporting evidence-based practice. I find that mostly with my nurse educator friends to be my most effective partners, but I've also found ways to make a friendship or a partnership with our chief nursing officer, who's very into making the big picture decisions and helping to determine how much financial resources a hospital may potentially provide for evidence-based practice. I've also found that presence and showing initiative is key to getting them to want to allow you to show your skills to provide support for evidence-based practice. In other words, I tell them you must give them a reason to recognize value. Just because we have the skills, if we're not out there showing it to them in a way, we're not going to get them to allow us to help. And that I feel supporting evidence-based practice is the best way to show value of a librarian, because any project that you do and which you have a hand in, which improves patient satisfaction or patient care, and which you can attach a dollar sign, is one way to say, look, I'm involved in this. It saved us $16,000. This shows the value I'm bringing to the organization. And that, lastly, when you're involved in this kind of stuff, the one thing I always stress to nurses is that evidence-based practice at the clinical level is no longer an academic pursuit. You are actually going to be affecting people's lives. You'll have yourself open to liability. And so it's key as librarians as well as nurses to be sure to seek out training to be a full partner that's able to effectively get involved in the various aspects of evidence-based practice. I appreciate your attention. I know I may have gone just a hair long, but I appreciate your attention. I hope that you found something of value here. For you all that are asking for resources, what you'll notice is that I put the link here, but also I think Liz will give it to you. And I agree with you, Jody. The critical appraisal tools or checklists that various groups have are very useful, but you also still have to have those skills in order to do that. As for you, Francis, I saw the thing here where you were saying you're getting pushback from your vice president who thinks everyone can and should do their own literature searches. My response to them is this, and this is how I sell my skills here, is you have biostatisticians who do the complex statistics when it comes to doing research projects. You wouldn't expect a PhD trained person to do their own statistics when it becomes pretty complex and money on the line. Why would you ask somebody who is dealing directly with patients to do the same thing when it comes to searching for literature when they may or may not have the skills to do that? That's an elevator speech to what I do. I sell myself like a biostatistician. I'm done, Liz, if you need to cut in here.
Yes, thank you, Roy. Thank you for your time today. I'm going to take back control, and I just have 2 quick administrative details to go over. So just so everyone knows, today's presentation was recorded and will be posted on our YouTube page, the NNLM YouTube page, as soon as possible. That's usually within the week. Here is a link to that page. It is the same one that is on your screen, but I will also be sending a follow-up email once that is available with the link to the specific recording and also a PDF of today's slides and that resource page that Roy has been referencing. And finally, if you would like to evaluate today's webinar and receive MLA CE credit, please visit the link on the slide, which I will also provide in the chat box. After you've completed the evaluation, you will receive instructions on how to claim MLA CE credit through the MedLibEd website. So if no one has any additional questions today, I want to respect everyone's time. I know we've just gone just over the hour. Thank you everyone for today's webinar, and thank you again to Roy for your time and your insight. So have a great afternoon, everyone.
And if you all have any questions, don't hesitate to email me.